I mean, I think
Okay.
with the
Hello,
younger,
everybody, and thank you for joining. And I'm glad I made it with plenty of time to spare. So, looking forward to this discussion: pushing innovation in acute myeloid leukemia, real-world integration of modern therapeutics into personalized patient management. So this is our panel. We have Dr. Uma Borate, Dr. Harry Erba, and Dr. Amir Fathi, along with myself. Thank you to the Health Tree Foundation for AML and PeerView for providing the session, and to AbbVie, Daiichi Sankyo, Astellas, and Servier for the educational grant to support the symposia. And there will be follow-up polling, so please do try to complete that if you are able. That would be very helpful. And if you have questions, you can submit them online. I have the iPad here, and we will try to address as many as possible during the Q&A. So the slides and practice aids are available for download if you want to note this down. This is the email address, peerview.com/23AML. Okay, so I'm going to just start with a very brief intro, and then we'll kind of go into the more detailed sections and discussions. I'm sure you all have seen many versions of a similar slide just showing the excitement and the progress that's happening in acute myeloid leukemia. 10 potentially drugs approved now. Quizartinib, we're hoping to hear very soon in the near future, and hopefully get it approved in the frontline space based on the Quantum First. But the other 9 already are fully approved. So this is great. The landscape is changing. The outcomes are improving, but there's still a lot of work to be done. And we're going to talk about some of those strategies going forward. And just kind of showing that even today, we're still seeing that intensive chemotherapy is commonly used, and that is reasonable if the patient is fit and healthy for intensive chemo. I think the bigger issue is still the use of single-agent HMA, and I've been in many discussions with many of you where I kind of find this still striking that close to 1/3 of patients are still getting single-agent HMA, even though HMA-VEN has shown such clear efficacy and activity. And maybe that's something we will talk about as we get into it, because I think, at least in our experience, we're not really using single-agent HMA for our AML patients. If they are able to receive therapy, it's usually HMA, venetoclax-based treatments. The other thing, of course, is that a lot of what you see published and presented at the big meetings, ASCO, ASH, EHA, of course, have a lot of focused heme data, is from big academic centers. And we are now seeing that the gap between what's happening in the big academic centers and in smaller community is actually getting wider and wider. The more drugs are available, the more the need for molecular integration of treatment. That creates, of course, good outcomes for the patients, but also creates hurdles if you don't have those tests available quickly or are not able to integrate that data. So we're still seeing that the testing for molecular is still not ubiquitous, close to 40% patients in this analysis that was done a few years ago, and I'm hoping that it will be better in the last 5 years, especially with more IDH inhibitors and a second FLT3 inhibitor and maybe menin inhibitors all coming. But still, there is work to be done. NGS is not a given. I get a lot of patients in my clinic today who either don't have the results or the test was sent and it's still taking 3 weeks, very commonly in many community settings. So I think this will have to change if we're going to really integrate frontline molecular treatments, which is the hope in the next 5 to 10 years. So the goals for tonight are to review the kind of baseline prognostic factors and prognostic markers, treatment selection in acute myeloid leukemia. Of course, go more into targeted and personalized treatment approaches in different acute myeloid leukemia populations, and then also to integrate newer treatment options into management of acute myeloid leukemia, and then also talk about toxicities, safeties. Each of these drugs has unique monitoring and safety parameters that I think are also very important to discuss and integrate as these very rapidly get pushed out from the clinical trials into the routine real-world use. We'd like to thank the Health Tree Foundation for Acute Myeloid Leukemia. This is a body that is doing great work empowering AML patients, focused on patient education and navigation, and also developing programs that can help create the patients to the appropriate clinical trials, academic centers, if they don't have any other standards or if they want to seek opinions, which I think in AML is really, really good given how rapidly the field is moving in new drugs and trials. are becoming available that may not yet have pervaded into the common knowledge in the community. And also, they're working to develop real-world data portals that could be used in the future for data mining and assessment of outcomes. So I think this is a really great initiative. You can look at the details there at healthtree.org. And I think for our patients who often get slammed very quickly with a lot of information, I'm hoping this will be able to give them high-quality, evidence-based data to help navigate some of the initial stages of AML, which can be quite overwhelming and difficult for a new patient. So we're going to move here towards FLT3, the biggest mutational group, 30 to 35% of patients, and a lot happening there among all the molecular groups. And I'm going to go through this polling question here. If available, what strategy would you select to manage a 50-year-old woman with AML? These are the mutations: FLT3-ITD, TNMT3A, NRAS, PS1, and has hypothyroidism, but otherwise generally fit. You see the options. I'm not sure. Midostaurin 7+3 induction, then transplant. Quizartinib 7+3 induction, then transplant. FLT3 triplet, so basically HMA, Ven plus, let's say, gilteritinib or quizartinib, either one. And then similar approach, but then no transplant, or transplant, no transplant, then transplant, either way. And I guess it will go to, okay. Okay, so a lot of people still with the midostaurin 7+3. We're going to discuss for sure the quizartinib 7+3 quantum first data, and then also some of the emerging data. This is a 50-year-old, so I think today I would also go with intensive chemo, although I am a little bit more in favor of the newer FLT3 inhibitors, but we'll talk about that more, the quiz and the GILT. So I think with this, okay, please rate your knowledge of the evidence supporting second-generation FLT3 inhibitor as part of induction platforms for newly diagnosed. So this is asking you how familiar you are. You're not sure of the evidence. Second generation we're talking about gilteritinib, quizartinib. So I'm not sure of the evidence in the frontline setting for those drugs with intensive chemo. I have limited knowledge, good knowledge, very good knowledge, excellent knowledge of the evidence with the second generation FLT3 inhibitors with induction. Well, that's good, because if everybody selected excellent, we'd just go to dessert right away, which should also be fine with me. So we have some work to do, so that's good. 60% are, I'm not sure, are limited. So let's see the next slide here. And with that, I am going to turn it over to Dr. Erba to get our knowledge bars to the right side.
Thanks, Naval. So the patient that was in the polling question is actually one of my patients that I treated this year. The only thing different on this slide is her name. We'll call her Susan, a 50-year-old woman with confirmed FLT3-ITD mutated AML. She presents with fatigue, with headaches, with blurred vision, actually, and dyspnea, and with an oxygen requirement. She has a performance status of 1 and only has a comorbidity of hypothyroidism. When she presents, she has a white count of 347,000 predominantly myeloid blasts with a hemoglobin of 4.5, platelets of 39,000. We actually don't do a bone marrow biopsy on her. The peripheral blood flow shows myeloid blasts. The peripheral blood cytogenetics demonstrates trisomy 8. The peripheral blood PCR, which we do because we get that data back quickly within 72 hours, shows FLT3-ITD, actually 2 internal tandem duplications with an allelic ratio of 1.7. And when we get the NGS panel back a couple of weeks later, she also has DNA methyltransferase 3A and NRAS mutations. So the question I want to address is, what are we going to do for a fit young patient with FLT3 mutated acute myeloid leukemia as new FLT3 inhibitors come into commercial availability? So let's first summarize what we know about FLT3 mutations. First of all, remember, FLT3 is a receptor tyrosine kinase that is critical to myeloid development. It is there for a reason. It binds the FLT3 ligand, it dimerizes, and then sets in motion a cascade of events that lead to promotion of survival and proliferation of bone marrow progenitors. FLT3 mutations are among the 3 most commonly mutated genes in AML, with DNA methyltransferase 3A and nucleophosmin 1. 25% of AMLs will have an internal tandem duplication that leads to loss of an inhibitory signal and has been associated with a poor prognosis, mostly due to an increased risk of relapse. About 5 to 10% of AML patients will have a FLT3 TKD mutation. However, the impact of the TKD mutation is less clear. For example, in this data from a German registry, where they looked at the impact of a single gene mutation on overall survival, you could see that FLT3 TKD was actually associated with a more favorable outcome than the FLT3 ITD, which was generally below that and associated with a less favorable outcome. And the reason for this is possibly related to the fact that the FLT3 TKD mutation is often associated with other mutations that are generally associated with a better prognosis, such as NPM1 and the core binding factor leukemias. The RATIFY trial was performed and has changed the standard of care as currently available in the United States and the world, most of the world, for patients with FLT3 mutated acute myeloid leukemia. Now, what you need to remember about this study is that it accrued patients with both FLT3 ITD and TKD mutated disease up to but less than the age of 60 adults. And in this study, midostaurin was included, or a placebo, for 2 weeks post-induction with 7 and 3, post-consolidation with high-dose cytarabine, and then 1 year of maintenance. And this, the primary endpoint was survival. It was met by midostaurin. There's a dramatic difference in median survivals based on where these curves are plateauing. I think a more reasonable view of the benefit is when you look at the 4-year survival, 51% with midostaurin versus 44% with placebo. And again, remember, this includes both FLT3 ITD and TKD mutated patients. Now, the standard of care for patients with FLT3 ITD mutated AML has actually evolved over the last decade, and we have come to realize that allogeneic stem cell transplantation is very important for these patients. And so what my colleague Rich Stone and the RATIFY investigators looked at was the outcomes of patients in this trial, whether they got a transplant in first remission or not. And as you can see, there is a clear benefit of midostaurin in the patients who underwent allogeneic stem cell transplant in first remission. However, if they received an allogeneic transplant at any time outside of first remission, so after relapse, did not get a transplant in first remission, there was no difference in overall survival. So the question that is in front of us is, can we do better than midostaurin? After all, midostaurin is a first-generation FLT3 inhibitor, which means it was selected because it had activity against FLT3, but it also has activity against many other kinases, both tyrosine kinases and serine threonine kinases. Second-generation drugs have been developed that are more potent and more specific for FLT3. Not purely specific, but more specific. There are also 2 types of inhibitors here. Type 1 inhibitors, such as midostaurin and gilteritinib and crenolinib, they will inhibit both TKD and ITD FLT3 mutations. A type 2 inhibitor, such as quizartinib or sorafenib, the first-generation drug, will only inhibit the FLT3 ITD because when a TKD mutation occurs, the FLT3 molecule folds into the active conformation and cannot bind those type 2 inhibitors. So the question is, can we do better than midostaurin? Here I'm showing you the results of the Quantum First study, and this is the design of quizartinib, a second-generation type 2 inhibitor with 7 and 3 chemotherapy versus 7 and 3 alone in FLT3 ITD mutated AML patients up to the age of 75. So there are a number of differences here that are really important to take into account when looking at this data compared to RATIFY. It included only the poor risk ITD patients, included patients who were over the age of 60. And in fact, 40% of the patients in this clinical trial were over the age of 60 in our study. The patients had to be newly diagnosed, of course, and they could begin 7+3 chemotherapy as soon as the diagnosis of AML was made and before they were actually registered and randomized on the trial while you're waiting for the FLT3 mutation. Very important when you consider how proliferative these patients, the disease in these patients can be. The primary endpoint was overall survival. The other difference between these studies is that the quizartinib was continued as a maintenance versus placebo after transplant and was continued versus placebo as a maintenance for up to 3 years. And here again, the primary endpoint of this study was reached with an improvement in the overall survival. Quizartinib median survival 32 months versus placebo 15 months for a hazard ratio of 0.776. Now, if you just look at this data alone and think about what you just saw with the RATIFY trial that also had a hazard ratio of 0.78, you're going to say there's no difference here. But these are very different populations of patients, and we need to take that into account for Susan's sake, because that's who we're treating here. We're treating somebody who we are treating for leukemia with curative intent. And so I think it is important to look at the subsets in this clinical trial with quizartinib. You might argue, why was the study done like this at all? Well, the first important point is that this study started in 2016 before midostaurin was even available in the United States. And the Senior Science Council that I led with Richard Schlenk in Germany decided that we would not amend the study after the availability of midostaurin, partly because it was only available in the US and took time to be available in other parts of the world. So that's why the control arm has placebo here. But remember, midostaurin has almost no single agent activity in AML. Almost no CRs were seen in the initial studies with single agent midostaurin. What's important to look at here is the cumulative incidence of relapse in the RATIFY trial on the left and the Quantum First trial on the right. The cumulative incidence of relapse at 2 years was just over 40%. With midostaurin in the RATIFY trial. And remember, that's including only younger patients, also with a TKD mutation, compared to 31% at 2 years with quizartinib in the Quantum First study. Now, why might this be? We saw other evidence of improved outcomes in terms of duration of remission and relapse-free survival. But what is the underpinnings of this benefit of quizartinib in addition to chemotherapy? And for the first time, we were able to show in a prospective trial that regardless of therapy, if the patient achieved an MRD negative remission, in this case using a very sensitive FLT3 MRD assay done by NGS, that there was a better survival in patients who were MRD negative. That's shown on the left. What you're looking at on the right is the plot of the FLT3 ITD allelic ratio using this MRD assay in all patients with quizartinib versus placebo. And there are 2 points here. There was a greater percentage of patients in complete remission with undetectable MRD with quizartinib than with placebo, 14% versus 7%. And the median FLT3 ITD allelic ratio was lower with quizartinib, 0.01% versus 0.03%. Now, you know, we all have eyes. We can all see these dots, and you're looking at this, and maybe you've had a glass of wine already, and you're thinking, this does not look very different between the two. But keep in mind the magnitude of the importance of this. This is after just giving 2 weeks of quizartinib. And very few patients go on to transplant after that induction. They get consolidation, they get maintenance. And so we're looking forward to more MRD data from this study. But what's important to me as a treating physician is I really think Susan needs to undergo allogeneic stem cell transplant in first remission. Unfortunately, a lot of things can happen to Susan that might preclude her from undergoing stem cell transplant in first remission. Now, we know most people will have a donor, but will she have a caregiver? Will she run into some kind of toxicity that keeps her from being a candidate for allogeneic transplant, or will she just say, transplant is not in my cards? So for me as a clinician, I want to know if the patient gets into remission, what is their outcome if they got quizartinib or placebo with or without getting the transplant? And here you see that analysis. It's a post hoc analysis of the Quantum First study that I asked the statisticians to give me. And this shows on the left, the patients who did get a transplant. But what's remarkable to me is in the patients who did not get a transplant in first remission, there is a clear benefit of quizartinib in those patients who achieve remission with a hazard ratio of 0.607. However, we have to keep the whole story in mind, because this study did include patients up to the age of 75, and it was an international clinical trial. And think about what was happening, because the accrual of this patient, I told you about the beginning, 2016, we didn't have midostaurin. The end of the accrual in the world was in 2019, April 2019, which many of you may remember as being 6 months after the approval of the accelerated approval in the United States of AZA with venetoclax, HMAs or LODAC with venetoclax. So we finally had an option for patients with AML that may benefit from a less intensive therapy. Now, we'll talk probably during our discussion about the benefits of those less intensive therapies in older patients. But the point of this is that when a physician in these countries saw a patient who was over the age of 60, they had to make a decision whether that patient was going to get palliative care and basically have a very short survival, or take a chance on intensive chemotherapy and put them on this study. And so, looking at the data in that way, look at the left-hand side. The hazard ratio here, in very small print, is 0.69, I think that number is, much lower than what was seen in the RATIFY trial in patients 59 and younger. And again, this is just the ITD mutated patients, but we did not see an improvement in survival. In fact, we have to be concerned, because if you look at the left-hand part of those curves, the midostaurin arm has a worse survival early on. And it makes you wonder if were there some things that we could have done or recognized in those patients in terms of supportive care, growth factors, or just selection of patients that may have impacted on that early mortality, because there was actually a trend for an improvement in median survival even in the older patients, and the hazard ratio there was 0.9 in favor of quizartinib. So getting back to the toxicities, spoken as a true leukemia doctor, when combining a third drug, quizartinib, with intensive chemotherapy and its continuation, we found this to be manageable. We're leukemia doctors. We find a lot to be manageable. Ask our patients what they find to be manageable. That might be a little bit different. But importantly, there were no new safety signals. Patients were allowed to get azole antifungals, strong CYP3A4 inhibitors with appropriate dose reductions. And in terms of grade 3 QT elevation on study, you can see it was 2.3% with quizartinib and 0.7% with placebo. However, there was a difference in 30 and 60-day mortality. And we have to take that into account, especially the myelosuppression that we will see with any second-generation drug that we add to chemotherapy. Crenolinib, gilteritinib, quizartinib, they are all active against wild-type FLT3, so we have to expect some myelosuppression. Now, these studies with other second-generation drugs have been done in phase 1 studies. Here's the data from Keith Pratt's with gilteritinib and chemotherapy in the newly diagnosed FLT3 mutated AML patients. You can see an amazing 90% complete remission rate. Now, again, this is both ITD and TKD mutated patients. What's not shown on the slide, however, is nearly half of those CRs, that CRC, half of those are CRIs, which are defined as incomplete hematologic recovery. And so some of these patients may have had just morphologic leukemia-free states afterwards. And so we're going to have to take that into account. These other drugs, gilteritinib and crenolinib, are being compared head-to-head with midostaurin in combination with chemotherapy. These studies started after the approval of midostaurin. So we have an appropriate control arm embedded in that study. The PRECOG study is looking at gilteritinib versus midostaurin in combination with intensive induction, consolidation, and maintenance. The primary endpoint there is MRD negativity after induction. As I showed you from the quizartinib data, we're hoping that that shows a benefit there, but that's a high bar. You're talking about showing a difference between those two regimens after just 2 weeks of the FLT3 inhibitor, and the proof of the pudding may be later on. So we'll have to see what that study shows. It finished accrual in November of 2022, so hopefully we'll have that by the end of this year, maybe even for ASH. The HOVON study looked at gilteritinib versus midostaurin with induction, consolidation, and maintenance. And the study was written with the primary endpoint of event-free survival. That's been amended because the study, partly because the study had to be put on hold because of a signal of neutropenia, which will affect the definition of the events. And so survival is the primary endpoint. And there we also have, finally, the crenolinib versus midostaurin study as well. So coming back to this patient, I'm not sure what you'd like me to do about it, but what did I do for this patient? I started her on hydroxyurea before I even could come in the morning and pontificate about the value of leukapheresis being questionable in any patient with AML. A pheresis catheter was already placed for pheresis, but it didn't work. And so she never got pheresis. Can you transfuse red blood cells? We were told we shouldn't, but she has a hemoglobin of 4. And so if you actually look at the literature, you can give some red cell transfusions. You just don't want to get them above 10. And then is a bone marrow biopsy required? I didn't think so. We don't need a baseline there. And I guess we'll leave it to the rest of the discussion, what we actually do for the patient.
Great.
Thanks.
Thank you. Thank you very much, Dr. Erba. Yeah, so, moving on here, I think we're going to discuss this more, the recommendations. Of course, we've already talked about giving FLT3 inhibitor plus the intensive chemo, consolidation, transplant, first remission. But I think let's leave that to the end of this section. Okay, so kind of going back, I guess the polling questions here, what strategy would you now select based on what you know with the recent data that Dr. Erba has gone through for the quantum first? So the same options here, please vote. Wow, I see a lot of percentages across 9 different categories.
That doesn't look right.
That's a puzzle.
Wait.
Maybe I had too much wine.
No. You forgot, we're in Chicago.
We're in Chicago?
Yeah, you could vote more than once.
You can vote. Okay, then. Somebody else might have had some wine here.
I didn't have any wine.
All right, so let's keep moving. I guess we didn't get that answer. Please reassess your knowledge of the...
We weren't supposed to get that answer.
I guess so. Please reassess your knowledge of the evidence supporting second-generation FLT3 inhibitors, part of induction platforms for newly diagnosed FLT3 mutated AML. Okay, whatever that means.
This is before and after, maybe?
Oh, I think you're right. Yeah, that makes sense. So 42 went down to 21. He didn't have any wine. There you go.
You guys gonna go on this?
Amir's on top of it.
Well, I want to see the last one then.
Okay, but let's see. So good and very good. So good moved from 19 to 47. So that's good. I don't know if we can go to the last one. Are we able to do that?
No.
No.
Oh.
I guess not. All right. Okay, so we're going to talk about maybe in the end, if we have time, we can try to pull that up. So maintenance, I think this is, so actually, just to highlight, I completely agree with Dr. Harry Erba. When you look at it visually, these curves look very similar, but the fact that these were all patients up to 75, 40% were older, and they were all ITD, to me, that survival curve by age, when you look at those below 60 and above 60, and that below 60, the hazard ratio is now below 0.70, in the ITD, when you look at the Ratify, there is a subset data actually. It shows the ITD low and ITD high, and both of the hazard ratios are actually close to 0.8 and cross 1. So I think for an ITD young patient population, and also given tolerability with quizartinib, we are more inclined towards the quizartinib aspect of it. Now, of course, gilteritinib versus mido, I think, will be a very important comparator. I mean, if that's positive, then yes, that would improve on the current standard of care. But if it's not, then I think we're kind of back to the drawing board to some extent. So now, what about maintenance? So you've got the patient through intensive induction, you've got him to remission, you've got him to transplant. What do you do for this patient? He has a known FLT3 mutation. Do you do maintenance? So most of the data, including 2 randomized phase 2 studies that use sorafenib, one was a German study, the other was from China. Both have shown actually very similar survival curves, very similar benefit in EFS and OS. This was the study by Burkhardt et al. From the German group. And so based on this data, and also many other phase 1 papers that had been published, we started incorporating maintenance FLT3 inhibitors post-transplant. Now, which is the best? Is it sorafenib, first generation, more toxicity, GVHD risks, liver toxicities, hand and skin? So people were a little nervous about that, and we've done it, but you have to really be on top of it and adjust dosing. So then, of course, we said, yeah, but now you have gilteritinib, quizartinib. These are second generation designed as FLT3 inhibitors, not mido and sorafenib, which were designed for solid tumors and then taken into the FLT3 space, and they have less of the GI and skin and GVHD toxicity. So this led to this large phase 3 study, the Morpho study. This will be shown about a week from now at the EHA meeting. Highly recommended for all of you interested in AML to look at this presentation, because I think you will realize why we should not depend on press releases to make any decisions. Many of us have seen the data, and when you see it, what was called a not positive study, I think you may come away after seeing some of the survival data that the question really is who should get maintenance, not whether maintenance should be given to all or none. You know, in medicine, rarely do we answer questions like that. It's really about who should get it. So the things I would focus on when you see that study are, number one, you have to realize that FLT3 is a very dynamic mutation. It can be gained, it can be lost. And at relapse, now we have 3 different data sets, all showing that anywhere between 45 to 70% of patients who receive a FLT3 inhibitor with induction either go to transplant or not, and relapse no longer have a FLT3 detectable at relapse. So it could be that if you're giving maintenance to some people who have achieved a very deep remission, there's no FLT3 clone, the FLT3 inhibitor is having very limited benefit. So you really need to know if that FLT3 was present, even at a low level, to know if the maintenance would benefit. And kind of in the same line, this was data from the Quantum First study that Dr. Erba and others led. This was a subset that was presented at the ASH meeting by Mark Levis, where they showed that if you were MRD negative, this was using a high sensitivity in vivo scribe molecular FLT3 PCR, if you were negative below 10 raised to minus 4, those patients after transplant, the benefit seems limited of quizartinib versus placebo. Those lines are overlapping on the left. However, if you're positive, even at a low level with that FLT3 PCR, then those patients who went to transplant, post-transplant, got maintenance, here is the benefit. So this is what you need to focus when you look at the Morpho, because I think over time it's going to become more of a question of how do you select those patients who will benefit from maintenance without having to expose everybody to it, because of course any drug post-transplant can create toxicities and issues. So look for some of that data. Here I want to just give a message out to how HealthTree is also trying to provide education to patients and caregivers, and especially in the FLT3 space. I think there's a lot going on there. But maybe we take a little bit of a discussion here. So to Dr. Erba, when you have a new patient, do you routinely send FLT3? How long does it take to come back? And what do you get back? Is it ITD, anti-KD, allelic ratio, allelic burden? What do you look for?
So I think it's clearly an important topic, a target. We need that data quicker than most people can get an NGS panel back. And so we do PCR right at the time of diagnosis, and we get it back within 72 hours. And when you do PCR, you'll get both the assay for the ITD and the assay for at least some of the TKD mutations, not all of them. That'll come on the NGS panel, but the most common TKD mutation you'll get from the PCR. And so you can, if you have a patient like Susan, you can start her on 7 and 3, send off that assay, and on day 3 or day 4 or day 5, get the FLT3 back, and it's positive for FLT3 ITD, then you can give what I would do, hopefully in the next few months, is give quizartinib. If they have a TKD, then I think there's a benefit of midostaurin as well. And so we have options for patients.
Great. So let me turn it here to Dr. Borate. So, you've participated, you've seen the data. What are your thoughts, newly diagnosed, quizartinib, midostaurin? What would you use for a young, fit, let's say 50-year-old patient coming with new FLT3 ITD mutation? And what would be the kind of pros and cons you think with those two agents?
So I think the thing from Dr. Erba's talk that I took away the most, especially in the younger than 60 age group, I mean, we saw the survival benefit, we saw all of that. But I think, again, I haven't used a lot of quizartinib, but I have used a lot of midostaurin. And what I think still scares me is the toxicity associated with midostaurin in addition to 7 and 3. I think with the GI toxicity, sometimes you can have not just severe nausea, vomiting, but even though we are leukemia doctors and we can tolerate a lot, I think when you see a patient, develop an ileus, go to the ICU, and have certain things that are related to a medication, I think it's really nice that we have an option with the second generation FLT3 inhibitor that maybe mitigates some of that toxicity. I think as we, if this is an option for our patients, as we use it more, I'm sure we'll figure out some unique toxicities to quizartinib, QTC being one of them. But I think that I find very appealing for a young, fitly positive patient.
Yeah, and I think we should highlight that, right? I mean, even though clinically we haven't seen much arrhythmia, we've used it a lot at MD Anderson, even the single agent, higher doses. You have to be careful, right? If it can very easily get a situation if you start giving levofloxacin, posaconazole, Zofran, and then you give quiz, that may become a clinical issue. So yeah, it's something that is seen, it can be managed, but trying to avoid too many overlapping QTC drugs, I think will be important as this goes out into the real world. Let me ask Dr. Fathi, so maintenance, what is your approach today in Boston for a FLT3 mutated patient going to transplant?
So it's currently not very data-driven. We use a lot of gilteritinib post-transplant in patients who have FLT3 mutations. Pretty much everybody gets gilteritinib. Now, we will all see in some fashion the results of the Morpho study in a week, 10 days. I'd love to get a sense of the reaction across the community regarding what that presentation will convey and how that will impact how we use FLT3 inhibition after transplant. That particular trial there was some concern around accrual to that study around the time that the Borate study that I think that was just presented by Dr. Dover was presented and then published, because folks were saying, well, it looks like FLT3 inhibitor therapy after transplant is necessary. It leads to improved survival. So it's very difficult to do a placebo-controlled study where a patient can be randomized to placebo after transplant. So at that time, I think sites either decided that they were going to stick with sorafenib or do their institutional experience, which in our case was gilteritinib. But that's what we do. And I'm personally comfortable using that agent following transplant.
Yeah, that's kind of what we do as well. But as you said, we will look at the data and dissect it and discuss it a lot once we see the Morpho data in the near future. So let's wait for that. And then with this, I would like to turn it over to Dr. Fathi to go over IDH mutated AML, please. Amir.
Great. Thank you so much. It's a pleasure to be here among friends and colleagues, and I appreciate Peerview inviting me to speak about IDH, which is perhaps not quite as apropos of the developments that have happened as FLT3, but still I think quite relevant. So here's my polling question. Hopefully we'll get a sense of the crowd here. Can you pinpoint practical aspects of care related to the use of IDH1 inhibitor platforms in AML? Pretty complicated question, but let's see. One of the choices would be I don't understand. So let's go and see what the crowd thinks. So 1, I'm not sure. 2, non-hematologic grade 3 toxicities are common. 3, responses are immediate, starting during cycles 1 and 2. 4, delayed responses may occur, potential for differentiation syndrome. And 5, hematologic toxicities are uncommon and rarely occur during initial cycles of therapy. inspiring guitar music. Sounds like folks are either not sure. Some 1 out of 5 feel that the responses are immediate. 4 feel that delayed responses may occur and there is a potential differentiation syndrome. I like that answer, we'll get to it. And 5, hematologic toxicities are uncommon. They are actually relatively uncommon. So let's move on. Okay, so Harry had his case, I'll have my case. This one I think is a little bit more of a standard case rather than one derived from reality, but we'll go through it. Michael, 74-year-old man, presenting with low platelets, have been worsening, as well as neutropenia. He has some comorbidity. I suspect fairly substantive comorbidity if it's mentioned here. An ECOG performance status of, I think we should just pick one of those. Let's go with 2. And the baseline testing confirms that he has an IDH1 mutation, he has AML, and his cytogenetics are indeterminate. I assume that is probably supposed to be intermediate, but we'll go with indeterminate. So the NCCN guidelines are provided here. This is for patients who are over the age of 18 who are not candidates for intensive therapy. That's either because perhaps due to their age or comorbidity, or that their physicians feel that they're not candidates for traditional induction. And the choices that are provided in NCCN really depend obviously on whether you have an IDH1 or an IDH2, but azacitidine and venetoclax is a category 1 for both. Ivo and azacitidine for IDH1, decitabine and venetoclax also for both, ivosidenib for IDH1, and enasidenib is also mentioned for IDH2, although I have to say that is not an FDA-approved indication for enasidenib in the frontline setting. So let's get into it. So the exciting Agile phase 3 clinical trial, placebo-controlled study of older patients, or those actually who are not appropriate for intensive induction chemotherapy, or 75 and older. This trial randomized patients to receive either ivosidenib, the IDH1 inhibitor, plus azacitidine versus azacitidine and placebo in patients with IDH1 mutated AML. And folks could be 18 and up, but like I said, it was for induction ineligible patients. And there was a 1-to-1 double-blind randomization of almost 400 patients with stratification by region and de novo versus secondary AML. And this combination was given in continuous 28-day cycles, with the primary endpoint being event-free survival, which it met very comfortably. As can be seen on the left, we have the event-free survival curves, which are quite separate from each other, almost a chasm when you think about AML in terms of ivosidenib and azacitidine versus aza and placebo. So obviously addition of ivosidenib decreases the events for these patients. And then overall survival, this also I think impressed a lot of us in the field. Here we have an impressive improvement in overall survival with a median overall survival that hovered around 24 months, which was quite remarkable. Now we have to keep in mind a lot of these patients are in their 70s, 80s, and 90s. 24 months, that is, I mean, where I started as a fellow 15 years ago, to think that patients in this age group would benefit with a relatively gentle combination regimen is quite remarkable. So obviously, this impressed a lot of folks, not only in the community, but among the regulatory agencies, led to the approval of azacitidine and ivosidenib in the frontline setting for older patients or those ineligible for intensive chemotherapy, in addition to the already present approval of ivosidenib as monotherapy for relapse refractory and newly diagnosed AML. So this was the original data. Now we have the update. Actually, the update, I think, was also presented relatively earlier today, and is also going to be an EHA update as well. I mean, I thought maybe it will settle out. It's even more impressive. Look, median overall survival of 29 months, and placebo plus AZA is as we would expect, around 8 months. So That's crazy, but pretty impressive. So Ivo plus azacitidine in patients with IDH1 mutated AML. So getting into the nitty-gritty, the composite remission rates of both arms are provided here, and there is an improvement in composite remission, 54 versus 16%. There's also other responses that were seen in the combination arm as well. Safety summary. So in terms of cytopenias, to be honest, there wasn't a substantial difference between the arms for ivosidenib and aza versus placebo and aza. Though the row that I'd like to sort of focus your attention on is the leukocytosis for ivosidenib and aza, although grade 3 or higher was not present. There are a subset of patients who develop leukocytosis, likely related to development of differentiation syndrome in that subset of patients who develop it with ivosidenib, the IDH1 inhibitor. Bleeding events were more frequent with ivo and aza than with placebo, slightly, 41% versus 29%. And then differentiation syndrome, which is an adverse event of interest with IDH inhibitors, both IDH1 and IDH2 inhibitors, occurred at 14% with the combination, which is in line with what we've seen with prior trials of IDH inhibitors, and apparently 8% also had it with aza and placebo. There have been reports actually of some differentiation syndrome with HMAs, probably not that high, but nevertheless. So few grade 3 non-hematologic toxicities. There were some cases of fatigue, pyrexia, and I guess diarrhea, although I have to say diarrhea is probably not a pronounced feature of ivosidenib, maybe more so with HMA. But it may take time for patients to respond, and this is key. We already know that it takes time to respond to IDH inhibitor monotherapy, but also with HMA, although the responses tend to be earlier, some people can take up to 3 to 4 months, 3 to 4 cycles to response. Hematologic toxicities can be seen, as is the case with HMA alone, and that is typically seen during the first cycle of therapy. However, there is an improvement in neutrophils and responders pretty soon after the start of therapy, typically within the first few weeks, within the first month. So that is noteworthy in terms of patients that ultimately end up responding. And because there is, as was mentioned with quizartinib, there is a theoretical risk. Well, there is a risk, but not perhaps for prominent cardiac toxicity, but for QT interval, I think we need to be careful about certain concomitant medications. Now, differentiation syndrome, previously described with IDH inhibitors. It's IDH inhibitors, their mechanism of action is related to differentiation and maturation of aberrantly interrupted myeloid precursors. So releasing that block in differentiation can lead to a very over-robust cytokine-mediated process that can lead to a pleomorphic symptomatology that includes high fevers, weight gain, edema, pleural or pericardial effusions, infiltrates, renal failure, adenopathy, you name it. And because so many other things can mimic it, oftentimes, if we suspect it, we treat with steroids, but also treat the other thing that possibly is being mimicked as well, such as infection or cardiac issues or volume overload. So, because if you don't treat differentiation syndrome and you say, oh, this is just bacteremia or it's an infection or patients just volume overloaded, patients can get into trouble. And patients have died, not necessarily on this clinical trial, but in previous studies and in experience if differentiation syndrome gets out of hand and patients end up intubated and in the intensive care unit. So it's very important to isolate and detect potential differentiation syndrome because it's very responsive to steroid therapy and oftentimes occurs concomitantly with leukocytosis and sometimes hyperleukocytosis. All right, so we talked about ivosidenib and azacitidine and its very impressive results to date, including recent results or soon to be presented results. But there are other options also for IDH mutated patients. Here we have the famed results of the VIALE-A, that's the phase 3 study that ultimately led to the approval of the combination of venetoclax and azacitidine versus placebo and azacitidine. Subset analysis on that study has been looked at several times, and populations of patients particularly IDH mutated patients, and particularly IDH1 mutated patients tended to do quite well. And that is also a combination that I think is increasingly used and considered in IDH mutated AML. A recent publication by Dan Pollier and colleagues from VIALE-A actually looked at the two subsets. Now, this is subset analysis. As you can see, the numbers are going to be smaller, and the number of events are also quite small. But I think you would agree with me that the curves in general are a little bit different. Suffice it to say that venetoclax and AZA is better than AZA, regardless whether you have IDH1 mutation or IDH2. So it seems like it's a good combination for IDH mutated patients. However, for IDH1, here you see, if you sort of look closely, at 12 months, you're looking at, so the median overall survival is hovering around 14, 15 months per se. It's much more impressive for IDH2. So, and it seems patients are continuing to respond and do very well. So we'll see what all this shows, but suffice it to say, this data is out there and people are gaining more and more experience. So let's go back to our dude, Michael, 74 years old, presenting with cytopenias. He's got comorbidities, he's got an IDH1 mutation, and somebody can't figure out his cytogenetics. Is this patient a candidate for IDH inhibitor and AZA or a ven-based regimen? Should I just go ahead and through this, or we can discuss it?
Yeah, just say
sounds
your
good.
thoughts and then
So at this juncture, and actually Dr. Davar and I were discussing this, I think 3-4 hours ago. I think this kind of has changed over time, our perspective on this. We were very excited, still super impressive results with ven-HMA, but the results emerging from IVO and azacitidine are quite unique. And I think accepting a scenario where a patient is so proliferative or so unstable where we cannot wait for the IDH mutational status to come back, I would use ivosidenib and azacitidine. And for whatever reason, there is not an available fast turnaround test, I can potentially consider using aza-ven because I think it's a very good regimen. But otherwise, I think the ivosidenib and aza is probably my personal go-to in that scenario, and goes to show you that I think having these results back in a timely manner is very, and also increasingly important, so that we kind of know what we can offer patients, particularly those who are not induction candidates. I think I already answered the second question, and in each case, what safety plans would need to be in place. So for ven-HMA, I think that's a bigger discussion because of the dose of venetoclax with concomitant medicines, duration of venetoclax and marrow suppression, the timing of the bone marrow biopsy and decisions that follow it. So I think it's a little bit more complicated, and I think there is a lot out there regarding each of those topics, all of which are very important and require some degree of expertise and experience. But for ivosidenib and azacitidine, I think two factors are several. So three key factors. One is you should give time for response. Although many people start to respond during the first cycle, some people take longer. Two, concomitant medications can be problematic. So if you're potentially using a concurrent medicine that also has a risk of prolonging QT, you should be thoughtful because ivosidenib can prolong the QT. And thirdly, the risk of differentiation syndrome. And like I said, if you have a patient coming in with fever, pleural effusions, infiltrates, things that you can't explain or potentially could explain, but the timing may make sense with peripheral differentiation perhaps, you should consider the initiation of therapy for DS, such as with steroids. Based on this presentation, the patient is likely a good candidate for IVO-AZA. If more aggressive disease had been present, then AZA would have been a good option also, and obviously what we talked about for that. Okay, so rethink your choice. Can you pinpoint practical aspects of care related to the use of the IDH1 inhibitor platforms in AML?
Wow.
All right, sounds like we've made some movement. That's great. So I think because I made fun of some people, they stopped they stopped picking number one and went with number 4.
Okay.
Great, thank you so much.
Good. So here we can kind of open it up a bit to discussion. So what are the thoughts? Maybe I'll start with Dr. Erba. So if you have a newly diagnosed older IDH mutated patient, what are your considerations? AZA-IVO, AZA-VEN? Do you differentiate between IDH1 and 2 in selection and prognosis?
Yeah. So it's great to have choices.
Yeah.
And this is a great example of that because both regimens, IVO-AZA and VEN-AZA, are benefits for our patients, especially older patients. But the way I choose between them really depends on what my goal is. So if I'm sticking to the labeled indication for either of those regimens, over 75, unfit for intensive chemotherapy, not a transplant candidate, I do think that IVO-AZA would be the way to go, and waiting for that IDH result to come back is important. Now, we do PCR and we get it back within 72 hours, but even if you wait for the NGS panel, think about this guy. This guy came to your clinic. He wasn't ready for you to say you need to be admitted to the hospital and get treatment, and he needs some time to get his affairs in the order. Or even if they come in with cellulitis or if they come in needing a transfusion from your emergency room, you can wait for this data. You can wait for it, except for the very proliferative state. So I would wait for it in that population. And the reason for doing it is partly the median survival of 24, now 29 months, compared to what we saw in VIALE-A. But really, it's the data that's been shown in the phase 1b and the phase 3 study where the neutrophils get better in the first cycle. And this is important in terms of patients having fewer numbers of infections, which they saw in the AGILE trial. And then on top of that, what's important is for the future of those patients, because as you know, treating these patients with AZA-VEN can be very complicated, especially for older patients. You're changing the dose, the sequence, the duration of the venetoclax from cycle to cycle. Here, once they get in remission with IVO-AZA, it's ivosidenib 500 milligrams daily with your choice of HMA. A lot easier for the patient. So I think it's worth waiting. Finally, on the other side of the coin, if I have somebody who is 72 and I know they have an IDH1 mutation, or I don't know, but I think this patient, once they get in remission, may be a transplant candidate, AZA-VEN gets these patients into a remission quicker. The reason why you don't see a remission quicker with the IVO-AZA is not because of the count recovery. That can happen more quickly. It's the blast reduction, which takes longer. And you're never going to convince your transplanters to take a patient to transplant if they still have 5% or 10% blasts. So it depends on the patient and how they choose between these. But it's great having options for both types of patients that we see.
And I think there's another kind of side to the coin, right? I mean, we're again at big academic centers, we get these results quickly. And I think the problem is, when the community doctor emails me and says, I take 3 weeks, I don't know if I'm that comfortable. It's debatable to wait 3 weeks for this 9% subset. I think that's where it's a little bit tricky. So now there's data coming out with sequencing, and I think that data will be very informative. I think we all, because of the label, tend to think that using AZA-VEN and then saving the back pocket, which is not something I like to say, but let's say using an IDH inhibitor in salvage will be the label way. But recent data that Max Stahl and some of the other colleagues have put together actually shows that if you use AZA-VEN up front at relapse, the response rate to IDH inhibitors was actually quite low, about 20%. And in fact, if you use the HMA IDH inhibitor, whether it was ENA or IVO, at relapse HMA-VEN, you were getting 50% response. So retrospective, small numbers, but I think we need to learn what we intuitively think will be the sequence because of the way they're approved may not eventually be the best way to use them. And then, of course, we're going to talk about neither of these are curing 70-80%. So can you then combine them? I think the bar is high here, right? With the AZA-VEN, IVO, or AZA-VEN, ENA, you really will need a few years of follow-up because they're already at 29 months. The 3-year survival is 40-45%. So you would need to see 60-65%, but that would be great. Maybe this is a subset like core binding factor that we can now put into the list where we can cure them. So I think we will see in the future. So Uma, in your experience and thought process, how do you approach newly diagnosed older IDH? Are you waiting? Are you starting HMA-VEN? What are you doing?
So we have a very similar process that was just described. We get the IDH mutation status back in about 48 to 72 hours. So I think we do have the luxury of knowing what the IDH mutation is and then really deciding, as was very elegantly described by both Dr. Erba and Dr. Fathi, the more proliferative, sicker patient, we tend to go with AZA-VEN. If you have time, the patient is not as sick, we do tend towards using AZA-IVO in that situation.
Great.
There's some clues sometimes to the patient with the IDH mutation,
Yes.
right? I mean, in my experience, when I've been waiting for it, it typically is a patient who presents predominantly with neutropenia, and the hemoglobin and platelets may not be that bad yet.
Yeah.
Typically pancytopenic patient.
Yeah, exactly. Especially the platelets. I don't know if we published, but yeah, this is something is very commonly seen. Platelets above 150.
Yeah.
You start thinking. That's a great point that Dr. Erba is making about IDH mutation. So you can get clues. Now, hopefully, the sequencing, it is getting better. I think every year, more and more centers are starting to get it sooner. So hopefully, we will get that data and be able to use it in the frontline setting for our patients. So with that, let's see. Okay, so we're going to now move towards the more difficult subsets for which we are still looking at new agents and hoping that there will be breakthroughs. And a lot of effort and research is now focused into these populations of older AML with high risk. So I'm going to turn it over here to Dr. Borate to start us off. Thanks.
Thank you. And I'm going to focus my talk mostly on something that has been brought up by the previous speakers a number of times. We've had the option of using HMA venetoclax now for several years. We're all using it in academic centers and communities. And my talk is really going to be focused on how do we manage using that regimen as effectively as possible for our patients, knowing that we're trying to develop, adding other agents, such as FLT3 inhibitors, such as IDH inhibitors, such as TP53-directed therapy, which then Dr. Davar will go over. So if you want to take a shot at the polling question about modifying the dose of venetoclax to mitigate cytopenias, does that necessarily impact long-term efficacy outcomes? Yes or no? If you're going to pick one of your options. Okay. So it looks like majority of folks have chosen number 4. Okay. So let's see what the data shows. So this is the patient, our hypothetical patient that we're considering for discussion here. This is Alice. She's a 75-year-old lady. She has de novo AML. And like a lot of our patients in that age group, she definitely has a declining performance status of 2. She has several comorbidities as are listed here. And in terms of the information you have, she has 75% blast. She really doesn't have any targetable mutations, so we're not going to argue about AZA-IVO, AZA-VEN, none of that, normal cytogenetics. So in her situation, what would your options be? And if you look at the NCCN guidelines, typically without actionable mutations, you have HMA-VEN, but specifically AZA-VEN as a category 1 indication. You obviously have the option of choosing decitabine. And then you have several other recommended options that we've sort of briefly mentioned, like Lodac-VEN, which is not used in the US as much. You also have single agent HMA, which I think, again, is something that we don't use a lot. And then you have other drugs like glasdegib, gemtuzumab, ozogamycin, and obviously there's always best supportive care if the patient is not eligible for therapy. But as we've discussed, we have a lot of AML drugs available, and so it would be really nice to be able to offer our patients something. So just going back to the updated data on VLA, this was presented at the last ASH meeting by Prats and colleagues, and we can see that with longer follow-up, this time about 43 months, that Ven-Aza continues to have a significant overall survival benefit compared to placebo plus Aza. And we've talked about hazard ratios a lot. Just to remind folks, the hazard reduction here was 0.66 at 75% of this OS analysis. And then the overall hazard ratio was 0.58. But again, as has been discussed extensively at this discussion and many, many other discussions that we all have, one of the limiting factors of how we can effectively use AZA plus VEN in the community and also in the inpatient setting and continue to give patients this therapy are the cytopenias, namely neutropenia, and then more importantly, febrile neutropenia, where patients get in the hospital, develop infections like pneumonia and so on. These are the cytopenias and infections that really keep your patients from continuing to get the therapy that they need in order to get that survival benefit. So in the VIALE-A trial, as you can see on this slide, that were really the notable grade 3 and higher events, were the febrile neutropenia events, including sepsis. And the TLS, which has been talked about a lot, especially in the CLL setting, was really not as much of a factor in AML. So with this, there was a really nice paper by Brian Jonas and colleagues trying to be as practical as possible in how do you dose AZA/VEN when you start a patient. And if you look at the label and you look at sort of the recommendations from this paper, what they're telling you is you start, as is recommended, you start both together. The cycle 1 dosing is 28 days of VEN, and you kind of go through that, and you get that first bone marrow biopsy, and it is really, really important to get that first bone marrow biopsy, because what you want to determine from that bone marrow biopsy, typically done between day 21 to day 28, is the patient in a morphological remission? And if the patient is in a morphological remission, you really want to take a step back and you want to see what is going on with the count recovery. And you want to give the patient time before you start that next cycle to recover their counts. And you don't want to sort of power through, because we know that this is a potent combination, and if you continue to treat the patient in significant cytopenias, that is not ideal for the patient, as we just saw with the complications of febrile neutropenia. So when you pause up to 14 days, you can use growth factor, and that's when you go on to the next cycle, and that's when you consider dose reductions or dose modifications. So there was this really, really, I think, informative publication by Prats and colleagues looking at a post hoc analysis of VIALE-A and really looking in depth at what happened to patients that were dose reduced after they achieved this first CR, CRI response. And how did those dose modifications affect the patient's survival sort of in the long term? So as you can see in this PowerPoint, in the slide, you have the 185 patients that were looked at. And then you can see there were a handful of patients that really didn't even have any cytopenias, and they weren't really part of this analysis. And then you have some others that had outcomes that were not something that they could continue to follow. But then if you look at the rest of the patients, you look at the 59 patients on the slide, you can see that most of those patients immediately got reduced to 21 days after they had their first sort of post-remission dose reduction. This was dropped to 29 days pretty quickly. And then you have these 71 patients that actually continued with the 28-day dosing, but in a median of 3 cycles, they also dropped their dose to about 21 days. And then you had a small fraction of patients that actually continued with the 28 dosing for a while. And if you look at the cumulative survival and outcomes of the patients who had their dose dropped to 21 days, whether it was right away after that first cycle or whether it was a little later on in the treatment, they actually didn't really have that much of a difference in outcome. In fact, their overall survival actually was pretty good and continues to be good as when this was presented. So I think the takeaway, which most of you actually guessed pretty accurately, that I see here is it is actually beneficial, I think, when you treat the patient in your practice, to really get that marrow between that day 21 to day 28, and reduce the dose of VEN if you think you've got the response that you need. So don't sort of power through, be patient, get the marrow, look at what's going on with the patient, and then dose reduce the VEN thoughtfully, because overall it really is beneficial to your patient to continue therapy for as long as they can with the appropriate dose of venetoclax. So in general, I would say, for most of us, if we get the IDH mutation or not, AZA/VEN is the standard of care for these newly diagnosed unfit patients. We know now that it's generally well tolerated. It doesn't have an inconsequential mortality. It's still 6 to 7%, so we all have to be mindful of that. There's clearly concerns with prolonged neutropenia, which we have to mitigate. And having that early bone marrow biopsy and then either dose reduction or dose interruption is really the best strategy to move forward with continuing therapy. And so far, therapy is indefinite in these patients. So going back to Alice, our 75-year-old lady with some comorbidities and a declining performance status, do you think this patient is a classic candidate for Aza-Ven? So I'll turn it over to you for more discussion.
Yeah, thank you very much, Dr. Borate. So maybe we can open it up here and, your thoughts, and then Dr. Fathi and Erba. So HMA-Ven versus HMA, we saw this polling, which again is probably a mishmash of different hospitals and community, where 26% are still getting HMA, and I've been in a lot of meetings and other panels where apparently these surveys are continuing to show that. Is this something that you guys have seen? And if it is, what is the kind of patient phenotype? Is it like this ultra rare 90 plus? When have you had to use HMA alone in your newly diagnosed AML? Any of you thoughts?
So I think I could envision just off the cuff, two scenarios in our patient population. One is the patient severely impacted by comorbidity, regardless of age, in whom we think venetoclax combination would potentially lead to marrow suppression that person could not handle. So I guess that would fit in with a much older patient with maybe kidney disease or heart disease or can't move. And so, if we're in a situation where I'm actually looking at a patient and borderline considering recommending palliative care or hospice, but there is still some, wanting of treatment, I might consider, dose-adjusted HMA monotherapy. The other scenarios, which are actually happening quite frequently, well, more frequently than you would expect, are patients who come in sick and end up in the ICU, in whom we have to start something, and venetoclax is difficult to give. At least we have to get the specific formulation to get it through the NG tube, and we don't have that. And we oftentimes start HMA therapy initially and sometimes get to venetoclax at some point in the future, and sometimes we don't. I think those are the scenarios that I would potentially think about, that we would use HMA monotherapy. I think short of that, I think HMA-Ven is the go-to for these older, less robust patients.
Harry?
So I'll take an opposite point.
That's the fun is, right? Yeah. Sure.
We've been agreeing with each other the entire
you're right.
evening.
Stop agreeing.
So I don't think there's a scenario where single agent HMA should be entertained in a patient who truly has AML. So getting back to the patient that you described, I've heard the same thing, right? The patient's too sick to get HMA-Ven. I understand that, but does that mean that the patient deserves to get HMA alone? What are you going to accomplish with that HMA? We know that the median time to response is months. We know that the complete remission rate is 20%. And so I get the feeling that you don't think they could tolerate the myelosuppression. On the other hand, I really think we need to make much more difficult decisions earlier on in these patients. We have these options, but I agree with you. You said the word hospice. Not every patient with AML needs to be treated, and they may have multiple comorbidities. They may be performance status 4, moribund, dementia, other active cancer. I think we have to be better at identifying the patient who we shouldn't even embark on treatment, because you know as well as I do, once you give that first dose of azacitidine or decitabine, you're committed to supporting that patient, and you've just given them a regimen that's ineffective compared to Aza-Ven. So I would argue that you should, if you're going to treat, you treat with your best agents and support them through that. Now, the situation that I thought you were going to get to was the patient who's intubated and you can't get venetoclax into the patient because there's no formulation,
Right,
or
that's
no
the NG
guidance
tube
of
one,
giving it down an NG tube, right? And that does come up. But in those patients, the more common scenario is, well, they're intubated because they have a leukocytosis. So give liquid hydroxyurea, give a single dose as you guys.
Cytarabine
of
or
cytarabine.
etoposide, some people do
Right,
that. Yeah, yeah.
one single dose. And then let's see how the dust settles, okay? And if they get through that neutropenic infection and they get extubated, then treat them with the best regimen. But I would argue not to start with an HMA. The other scenario I've heard that said is, okay, well, I can start HMA in my clinic, but it's going to take a week to get the prior authorization and the copay assistance for the venetoclax. And so you finally get the venetoclax on day 8, and then you add it in. We don't know if you're adding in anything more than myelosuppression at that point.
Yeah, I think also you have to realize you don't have to give Ven 21 days, right? We didn't talk about it, but there's very nice data from the French, Stéphane Botton, doing 7 days of HMA Ven. So I think the scenarios where I have given HMA alone are very, 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 very rare. The one I would actually think about is what we discussed earlier this afternoon, where it's TP53 mutated, older AML, 78-year-old. Yeah. In our group, among the AML experts, there's a big divide there. The survival is 6 months flat in both studies. If you're not going to take him to transplant, if you're going to take him to transplant, I agree, HMA Ven, 55%, CR is better, you go for it. But if you have a 77, 78 who really wants treatment, agreed, we can always discuss palliative, that is not unreasonable. Would I prefer to give HMA Ven versus HMA? I think that is a debatable scenario. But then giving less is something I've commonly had to do, right? If I have actually Dr. Ravandi has a 98-year-old patient, 4 years in, you've probably heard it because it's quite a cool story, he says it all the time. She's 4 years in, but she's like on teeny tiny doses by now, like 3 or 5 days of HMA Ven, but she's alive and she's getting it. So if I had to choose, I kind of agree with Dr. Erba here that the quick response, right, for a really sick patient is kind of what we would do. I always agree with you, Amir, I have to. But yeah, I mean, I think in general, I would say 95%, right, we're using HMA Ven in most scenarios.
I have to agree with Harry as well.
Oh my God.
He's right.
Oh, okay.
He's right. He's right.
We should close on that note, but no.
But it is an important subject. Let's come back to the French data, right? It's all retrospective.
Sure.
But what I found really interesting about that is 7 and 7, right? 7 of AZA, 7 of venetoclax. And what were they trying to do? They were trying to decrease the toxicity, right? Of course, that's what they're trying to do. They got the same response rate. They got the same median survival. They got the same toxicity in the first cycle in terms of myelosuppression. Why? Because these are sick marrows to begin with. And so I don't think you have to give 14, 21, 28 days of venetoclax.
Right.
But I think you need to give some venetoclax with azacitidine. Otherwise, you have venetoclax alone with a 15, 20% response rate, mostly in IDH mutated, and 20% response rate with azacitidine. Put them together. I don't know how to do that, but if you at least give 7 days of both, I think the French have said you can get them into remission, but you're still going to have to support them through that narrow failure.
But that being said, with the French experience, at least we have seen when you give less Ven in that first cycle, it is not that severe the infection risk in most patients. With the DAC 10-day, we looked at it. So if I had to err, I may just go a little bit lower, but it's not going to make it zero in that case.
You say 98 years old. I remember I had a patient who was 103.
Oh, he wants to go higher.
No. And she was quite spry, and I tried to get her on a clinical trial. Unfortunately, the number of digits in their computer system to allow patients on only allowed 2 digits.
Are you kidding me?
Yeah, so I couldn't. Should be a perfect clinical trial candidate otherwise.
Can I just push back about the P53 for a second?
Sure.
We still have 3 minutes, right?
Well,
So-
3
no,
minutes, but we have the whole section. Let's go on.
Okay, go do that.
Yeah, because we're actually kind of short on time.
Oh, I'm
because we are going to talk about TP53 here. So, what about high-risk patients who have the mutations like TP53 MLL? So I'm going to kind of go through some of the emerging drugs, a lot of these coming up. So we have not stopped our research in AML. I think there's a lot more to be done. The biggest group, I think, that is today unmet need is TP53. Whatever therapy you look at, intensive chemotherapy, HMA alone, decitabine 10-day, HMA Ven, we're at kind of 6-month survival. So APR and CD47 antibodies are kind of the approach we're looking at. This is a kind of the first immunotherapy that looks like it's really moving forward in myeloid malignancies. The way it works is by inhibiting the interaction between the tumor cells and the macrophages, which actually dampens macrophage activity. So it's kind of like the same thing with PD-1, PD-L1, but instead of T cells, here you're blocking the interaction between CD47 and SIRP-alpha, which actually sends a dampening signal to the macrophages. So by blocking that signal, you unleash the macrophages to attack the tumor cells, in this case, myeloid cells. So this is the data here against in the TP53 mutated AML. This was probably the largest frontline interventional TP53 kind of focused effort with 72 patients enrolled. Majority of these, about 90%, were what we would consider multi-hit or true TP53 biallelic, whatever you want to call it. And overall response rate, about 50% with the CR rate 33%, and duration of response is about 8.5 months. So when you look at the HMA event, it's published by Dan Pollier in Clinical Cancer Research, in this similar biallelic high-risk TP53, we see CR rate of about 20% and the CR/CRi 40%, duration of about 4 to 5 months. So it's not going to be a blockbuster, but hopefully at least a step forward. Now this is being looked at in a randomized study. We hope to have those data actually in the near future. And there are, in fact, 2 randomized studies. One is TP53 focus, which I'm kind of more interested in because I think we really need something to move the bar then, and then we can start working on other approaches, cellular therapies, et cetera, to further improve that outcome. So that's the first one, the enhanced 2, looking at AZA/magro versus investigator choice of HMA ven or intensive chemotherapy, because actually many centers, especially ex-US, still like to use intensive chemotherapy for TP53, so you can choose either one, and the primary endpoint is the survival. And then the other one is actually kind of the VIALE-A study, but with the addition of magro versus placebo, so all comers, older, unfit AML, to see if the 3-drug combo will just improve survival across the board and become a new standard. So we have to wait for these data. What about the menin inhibitors? So this is kind of some of the key data that was shown from the menin inhibitors. This is the ziftomenib. This is data that was presented and will be updated by Dr. Fathi at the EHA meeting, showing very encouraging response rates with the menin inhibitors. We've already seen publication with the Syndax compound also showing a high response rate. Now, it's not high numerically, but these are 4th salvage patients. So the CR/CRi, CR/CRh rates of 30 to 40% are really quite striking because 5 years ago, 4th salvage menin MLL rearranged patient, we would be sending 90% of them to hospice. So in that population, to be able to get 40, 50% response is itself, I think, quite amazing. And I think once we incorporate these up front, we hope it will be even better. So last few things, I'll just go over some of the new combos. That's an area of big interest that we're kind of focusing on at MD Anderson, all of us now in multi-institutional trials that have started. So this is the doublet of venetoclax gilteritinib. We published this at the JCO last year. And as you can see, the combination is quite effective at achieving marrow clearance, but we do see myelosuppression. This is something we have seen with many ven combinations. But again, if you have a patient below 74, 75, your goal is to get that 2nd or 3rd relapsed FLT3 AML into remission and move them to allotransplant. This is a very effective regimen and one we are routinely using for our patients to move them and bridge them into allogenic stem cell transplant. But if you're going to try to do this in an older patient, 75, 77, you have to really start de-escalating the venetoclax very quickly. In fact, even in the first cycle, we often start with just 14 days, and then if needed, use growth factor support. This is just showing that even in these salvage patients with this combo, if you take them to transplant, you can actually achieve good outcomes, which is not something we would have seen 5, 6 years ago in relapsed refractory 2nd and 3rd salvage FLT3 mutated AML. Of course, then the question is, if this doublet is doing well, at least in getting marrow remissions and clearance in the salvage setting, can we move it to the frontline setting and maybe have less myelosuppression, healthier marrow, patients have not been exposed to intensive chemo, and relapsed refractory multiple prior therapies. This is the data that was presented by Dr. Short from our group. It is quite hard to argue. 27 patients frontline now enrolled with 100% overall response rate, but even more interesting, the true CR rate, full count recovery, which has been the big concern, but now with optimized dosing, that is the key, 14 days only of both ven and gilt, which we had to slowly come down to working with the FDA. We are seeing count recovery is quite good, and the OS is looking encouraging, but the follow-up is only 1 year. So let us wait to get a little bit more follow-up, but people are now asking the question, well, if this data holds up, why should we reserve this for your 75, 78-year-old? Can we start moving slowly down the age? And randomized studies are being planned to look at that question of HMA ven FLT3 versus intensive chemo FLT3, which is amazing. I don't think 10 years ago any of us would have foreseen such a question even coming up for discussion. I think with these triplets, the key is really reducing venetoclax. I think you have to make space for that third drug. And it's okay because as the French have shown, as we have seen, others have seen, you don't need 21, 28 days of ven, and that will block the third drug from being added. So now, over time, working with the label and FDA, we have now been able to come down to 14 days of ven, and even the FLT3 inhibitor, we're actually starting to cut that even at 14 days. So the 14-14 approach, maybe like the 7-7, is what is moving forward into a larger multi-center study. And with this approach, 14 days of ven and 14 days of guilt, now the count recovery is actually pretty good, about 35 days, which is similar to the 33, 34 days that was actually seen in the VIALE-A with HMA venetoclax. So always takes time, but I think we are now close to a regimen that can be moved into a multi-center study, and this is the multi-center study that is ongoing. Many of us and others are participating to finally optimize this dosing regimen and potentially move it into a regulatory or guideline-based use. And then, of course, randomized studies. What I would be very excited to see is comparing it to intensive chemotherapy. It would be great to not have to use that in the future. Quickly, similar data being generated by Dr. DiNardo and Dr. Lakowitz, who was our fellow, who's now at Oregon, showing also the triplet of HMA ven ivo is highly effective. Here, I think the bar is higher because the median survival is already now 29 months as compared to FLT3, where the median survival of HMA ven is 11.5 months. So the bar will take longer. We will need more mature data, but the response rates do look very, very encouraging. And then lastly, of course, the TP53 group, similar question, and we may have a little chance to discuss this, is whether HMA alone is sufficient and HMA magro is all you need, or does HMA ven still add that response component? Maybe the survival is not that much better in TP53, and should you do the 3-drug combo? Preclinical data suggested by Marina Konopleva that the 3-drug combo was effective at promoting more phagocytosis and apoptosis. So we have kind of taken that forward, and in this study, at least, it did look that the response rates were better compared to what we had seen with the doublet, with the triplet. But I think these numbers are quite small, so we have to wait for randomized enhanced 3 data. And I think this is, again, a good problem to have. Do you need AZA magro? Do you need the triplet going forward? CD123, there's a lot of efforts ongoing with this. One of the lead drugs here is a drug called IMGN632, or pivekimab. This is actually being developed in the frontline BPDCN space, where it is actually currently in a regulatory approval-based protocol, but in AML is also being evaluated in the frontline space in combination with HMA ven. Similarly here, we are now down to 14 days of ven, and in fact, the response rates are looking quite good. This was the early data in the salvage setting. We're seeing close to around 45-50% overall response, but the focus will now move to frontline, and that data will hopefully be at the ASH meeting later this year. So just to close out here, just kind of again highlighting our partner who's been very supportive and is kind of more focused on patient education. This is the HealthTree team, and now they have a number of different courses and videos. They've done a lot of work in myeloma. I think that's kind of been their base, but they're moving more into the AML, and please go check this out when you have an opportunity. So I think what we're going to do now is do this question and then do some of the Q&A. And then try to close out maybe just a few minutes late. So polling question, we'll go quickly through this. Modifying the venetoclax dosing, do you think that this is something that can be done without any major impact, or do you have other suggestions? So let's do that. Okay, and I think Dr. Borate nicely highlighted. I like that paper by Keith Prats very much, really digging into VIALE-A. Great commendable effort to the Keith and the team for looking at that in the venetoclax to show that you can safely reduce dosing, which opens up now potential to add the third drugs and further improve that survival curve. So there's a few interesting questions. Maybe we'll go over a couple of those. So one of those questions is an interesting question. We didn't mention this, but Dr. Kantarjan got the Karnofsky Award, very, very, very well deserved. And he talked a lot about how, when he started, the cure rate for all leukemias except APL was less than 30%. And that included chronic diseases. Now, almost all of them have moved to 80, 70, 80%, ALL, CML, CLL, younger AML. Of course, we still are remaining now with TP53 and others. But he did make a statement, and this is the question actually. Does the panel agree with Professor Kantarjan's statement in his Karnofsky lecture that venetoclax will become part of standard of care for most, if not all, AML patients? So thoughts on that? Maybe Dr. Borate.
I mean, I think it's definitely part of every backbone that we want to add to. I mean, I think it's hard to argue with the VLEA data and the progress in terms of against, single agent HMA, and I think that's why you nicely highlighted all the different triplets that we're trying to do. But I do think what you mentioned and what the Pratt's paper showed very elegantly is that we need to find the right dose of ven. And I think, we've all said that, the data is showing that, and I think moving forward, if we can find the right dose of ven to combine with HMA, it's a beautiful, extremely potent combination. We want to use it well, we want it to benefit our patients, and then hopefully we want to add more drugs that can target other parts of the patient's disease and get that curve to, be even wider and longer in the future.
Yeah, I totally agree. I think we're now in the phase of kind of optimizing ven and trying to backtrack down to the needed dose, kind of like the Project Optimus approach, right? But it's just taking longer. We're going backward a little bit, and then seeing how we can, because the other statement that he has made that many of you heard is that the current label and duration of ven is really becoming a big hindrance to develop the new combination. So now I think finally the FDA and a lot of efforts are moving us back to a level where we give it sufficient to achieve response, and then people stay on it for longer, many years, which is kind of the goal of treatment. Let's take maybe a couple of questions. So maybe to Dr. Erba, is the incidence severity of diarrhea different between FLT3 inhibitors? In early trials of midostaurin, GI toxicity side effects were a problem.
Yeah, so the interesting thing about the GI toxicity that we all experience, our patients experience with midostaurin, was actually never captured in the ratified trial data. If you look at that publication, the difference between the midostaurin and the placebo came down to a higher incidence of rash, anemia, I think there might have been one other thing, but never mentioned GI toxicity. And the reason for that is that toxicity data came from the induction, where the study drug and placebo are being given at the time of mucositis. So patients either, most of them, it diluted the number. A lot of patients already had problems from GI toxicity. And what's really important to look at is what is the toxicity of the drug during maintenance. The reason why, I think quizartinib may be a better drug, especially during maintenance compared to midostaurin, is number one, quizartinib does have single agent activity, midostaurin does not. And number two, in the patients that I've treated with quizartinib, I have not seen significant GI toxicity with that drug. Whereas when you're giving midostaurin, patients complain of the smell of it. They have to take ondansetron before each dose, leading to constipation and much more GI toxicity.
Yeah, totally. And even, gilteritinib, which is a fantastic drug. I mean, the safety profile is great, but we have seen GI issues. I have seen it with gilteritinib, especially in post-transplant. Most of them are minor. You can dose reduce to 80. But you're right. From the GI point of view, quizartinib has the least. Now, of course, you have to monitor QT, and there are other things. But yeah, GI-wise, I think there's a big gradient. And just quickly to answer that question, somebody else also answered, do we think the GI toxicity is due to hydroxyurea, which most FLT3 mutated patients receive, not as much as FLT3 inhibitors? I don't think so, because as we were discussing, we see a very different profile with the different FLT3 inhibitors. So maybe let me ask Dr. Fathi one question here. What percentage of older AML patients do you think receive unmodified doses of HMA ven? For patients requiring ven dose modification, in which cycle is this commonly happening? And I think they're asking just what is your perception or observation of patients referred to you? What are people doing before they come to the big academic center? Are they giving 28? Are they giving 21? What's happening?
I think there is a range. Unfortunately, MDS and AML are relatively uncommon diagnoses in the community who see a lot of solid tumor and lymphomas. So I think gaining of experience and interacting with us as the sort of the cancer center is important, because the label simply says 28 days or continue until you do a marrow at the end of the cycle. And and in my view, and I'm preaching to the choir here, I think that's a bit of a overdosing of venetoclax, frankly, because people develop a lot of marrow suppression, get into trouble. And in fact, when the drug was first approved, I think probably all of us saw a lot of patients coming in with big bad infections, bleeding, complications, trips to the ICU, mainly because people were kind of managing it as they were with HMA monotherapy, which is now in hindsight quite dangerous. It's kind of like flying without a pilot because you kind of don't know exactly what's happening in the marrow. So what I generally recommend and what I always try and preach is to do a marrow biopsy around day 21. And if the marrow comes back with hypocellularity and suppression of blasts, which we call ablated, we recommend holding venetoclax and delaying initiation of the next cycle until there is some degree of count recovery. And generally, we hold at least 2 weeks to accomplish that if we need to, and sometimes longer. Once it gets beyond 3 to 4 weeks, I get nervous that perhaps things aren't going well and maybe they need another marrow biopsy. But generally speaking, that's been our approach, and we've had success. I'd say the large majority of patients either recover their counts or get into a remission, or they don't, and they have persistent disease that will reflect itself that cycle or the subsequent cycle or the cycle after that.
Yeah, and I think it's nice to see, right? 3-4 years ago, I think it was a little bit divergent. People were doing different things. I mean, this meeting, and even over the last 1.5 years, almost everybody in the academic who's now had nice exposure and time to use HMA-VEN is doing something very similar. 21, 28 is fine, but they're stopping after the marrow. Once you show remission ablation, they're giving time, and most of us are then reducing quickly to 21 or 14. So I think there is unanimity, and we just now need to work with the FDA and others to get this
as you were saying
approved.
earlier, the key is to prime these patients so that they can stay on something for as long as possible and benefit from it.
Exactly.
That's ultimately what we're trying to do,
Exactly.
not hammer them up front and decrease the duration that they can
That
use
they'll
the
get the
drug.
drug. Yeah. So last couple of questions I'll take quickly. So one is, in the Magro enhanced study in TP53 fit patients, how do you select patients that go into the IC cohort? It is investigator selection, so they will decide before randomizing the patient if they want to do intensive chemo or low dose. It's going to be very different geographically. In the US, I think many people are going for HMA-based, HMA-VEN for TP53, although I've been on many investigator calls and steering committee, and in Europe, that is not the case. They are actually putting 80-90% of their patients with TP53 on intensive chemotherapy. Part of it is the label. They cannot use off-label insurance. But I do think we will see a mix of those patients based on geography. And then the last one, in the Magro study, unfit looking ahead, do you think the triplet is going to be best option? I don't know. We will update the data at ASH. I do think that the doublet in TP53 is actually looking pretty good, so we will have to wait and see as we get more data coming forward. So with that, we're already a few minutes over. I'm going to move on and close us out here. Thank you so much for all of you joining. Again, this is the website for those, if you wanted to go back, look at slides. The slides will be available for download, as well as the recording of this discussion and meeting. Because you love us so much, you can listen to us again and again and again. Or not. And with that, I would like to thank you all very much and have a good Saturday evening. Take care. Bye.